Any copying, distribution, or public performance of this video or slides is strictly prohibited and may subject the offender to civil liability and severe criminal penalties.
The 94th Annual Meeting of the American Academy of Periodontology. Tissue-engineered solutions for aesthetic dilemmas.
Couple of announcements that really speak for themselves is number one, I'd kindly like to ask all of you in the audience to silence your electronic devices, including cell phones and pagers. There's nothing more distracting than one of those going off and playing the speaker's least favorite song while they're trying to concentrate and speak. It's really disruptive not only to our speaker but to the entire audience as well. There's not much time left. I think the hall closes at approximately 3 o'clock, but I strongly urge you to stop by the hall. One last look at the vendor supplies. It's important that we support those individuals that help make this meeting an ongoing event. And of course, the CDs and DVDs of any of these sessions are really of high quality resolution, so you don't necessarily have to take copious notes while Dr. McGuire talks today. Well, I'm given the honorable task of introducing our speaker today. There are certain names in certain disciplines when you say them, like in baseball, if you say Ichiro, or in basketball you say Shaq or Kobe, you know who they are. In periodontics, when you say the name McGuire, everybody knows who it is. This gentleman's resume is long, distinguished, and well-deserved. It's really my honor and privilege to introduce to you today last year's Master Clinician, Dr. Michael McGuire, who will be speaking today on tissue-engineered solutions for aesthetic dilemmas. Dr. Michael McGuire.
Well, thank you, Paul, for the very nice introduction. It's always an honor and a pleasure to have the opportunity to present at the Academy. I don't think there's too many people in the whole meeting, much less in the hall here, that would take exception to the fact that probably today implants and periodontal plastic surgery are the strongest growth area in our practice. We're fortunate that in periodontics we really have the leaders in tissue engineering in all of dentistry. And the organizing committee has asked that I share with you some of our clinical research focused on tissue-engineered solutions for aesthetic dilemmas, and I'm of course happy to do so. This is really our passion in our clinical research is tissue engineering related to soft tissue defects, and I'm going to share with you a number of studies that we've published, but just very briefly, primarily as background material, how things have evolved, and then spend most of our time this morning talking about 3 studies that we've completed but have yet to publish. Now, when it comes to tissue engineering, if I can get there we go, soft tissue engineering, our objectives are to, in certain instances, increase keratinized tissue, augment papilla. That's something we've not been able to do with traditional periodontal plastic surgery, so we're all looking for options to allow us to do that. We're looking for ways to improve our abilities to cover denuded root surfaces, stimulate wound healing. That's an interesting thing because that's something we haven't been able to do. It's something really I haven't even thought about until the last 5 years or so. What happens if we can place an agent in that stimulates wound healing? And then, of course, the holy grail, regeneration. Not just repair, but achieving regeneration. And I'll share with you this morning studies in which we've been able to accomplish each one of these objectives using tissue engineering. And we also want to be able to do this, clicker here is having a problem, without a donor site. We want to do it with reduced morbidity and increased predictability for our patients. We want to have more robust results, a more natural outcome. That's another kind of theme that we're going to be talking about. With today's surgical guidelines, we can pretty much predict what we can do and what we can't do. I think the next level is to be able to take it such that our outcome is indistinguishable from what Mother Nature really expected there to be there. And then we want to do it with an unlimited amount of donor material. A lot of times today we are having to limit the amount of treatment based on the fact we just have to treat the worst sites because we have a limited amount of donor material. And then finally, with less technique sensitivity. This last one, less technique sensitivity, is also an interesting one. You know, what makes the difference between a master clinician and an average clinician? Well, a lot of things go into it. Maybe the way flap design, your incisions, the way you manage the soft tissues, your suture techniques. Well, what if I have a tissue engineered construct that I can slip underneath the flap before I suture it that stimulates wound healing? That could compensate for a lot of those small inadequacies and move average clinicians into master clinicians and really level the playing field. And I think that's another area that we will see tissue engineering really altering the landscape of periodontal plastic surgery and all of our surgical procedures. I'm absolutely convinced that in the future, you and I will not be performing any passive surgeries. All of our surgeries will have an active component to it, and it will be tissue engineering that will provide those active components. Now, I've been asked to disclose, as all presenters are, that most of my research has been funded by different companies. They're listed here on the board, but I always maintain complete control of reporting of all of the data. Now, when it comes to tissue engineering, I think of it as a matrix or a spectrum. And on one end of the tissue engineering spectrum, we have the live cells. On the other end, we have the bioactive molecules. And we're going to begin by talking about the live cell end of the tissue engineering matrix, studies that we've done by implanting living cells into the host to try to stimulate activities that we're interested in. Now, as you begin to think about soft tissue engineering, there's two basic lines of research that you kind of start bumping into: biologically based devices and live cell based devices. And they're very, very different. And you almost have to start having a different kind of mindset as far as expectations from these type of grafts. Now, when it comes to biologically based devices, the most common one that we're all familiar with is acellular dermal matrix. You know, it is basically a immunologically inert allograft. It's capable of fibroblast migration, revascularization. But the bottom line is this is a dead piece of tissue, and it brings nothing else to the party. It's just a tissue replacement graft, nothing else. That's very different than live cell-based devices. Live cell-based devices are much more than a tissue replacement graft. Think of them as a little factory that they're bringing in all sorts of things. They're bringing in cells, they're bringing in cytokines, they're bringing in glycosaminoglycans, collagens, all sorts of things that are going to stimulate angiogenesis, are going to stimulate pathways toward regeneration, and in my mind, most importantly, they're going to deliver it on demand. Now, think about some of the biologic mediators that we've known about for a long time. Let's pick BMP, for example. You know, we know that's a strong bone-stimulating protein. We place it into the defect and we stand back and we wait for magic to happen. Sometimes magic happens, but oftentimes magic doesn't happen. What's the problem here? And I don't mean just with BMP, I mean with any mediator. Well, how do we know that it really got to where we want it to be? How do we know when it got there it stayed there long enough? What do we know about the concentration? Did we have too much? Was there not enough? Was it still viable? All of those variables are very difficult to control. Yet with these live cell-based devices, these cells are talking to each other, and they're talking to the native cells in the defect. And they then theoretically can physiologically titrate the amount of these biologic mediators necessary in order to kick off the regenerative cascades, to do all the things we're wanting to do. So this is a very different system than what we've been thinking of in the past. Now, the first live cell-based device that we did research on was the living human fibroblast-derived dermal substitute. This is at about 4 or 5 days. You're seeing human fibroblasts lying in parallel with collagen. These fibroblasts come from neonatal foreskins. It's a very neat little way for a donor source. These single cell or single donor cell lines have a lot of nice things about it. You know, if you're using cadaveric tissue, even though you're going to test, there is a limit of how much testing you can do if you're having to do this on multiple cadavers. But on single donor cell lines, It gives you great uniformity, great availability of the cells, and extraordinarily ability to test these things. Now, fibroblasts do not elicit an immune response, so that we don't have to worry about. And these fibroblasts are grown in this particular system on vicryl sheets. This is an SEM of this material at about 5 days. These are the vicryl fibers, and you're seeing the fibroblasts stretching across. And so we place this material into the defect. As you know, the vicryls lost through hydrolysis. It leaves behind not only the fibroblasts, but the collagens, the glycosaminoglycans, all of these things. Think of it like a little factory. So we're placing this metabolically active graft in the defect, and then it's stimulating wound healing, regeneration, all of the type of things that we're wanting to do here. Also, my computer is slower than me. Also, it stimulates angiogenesis. Here is just the vicryl material itself, and here is the test material at 3 days. And look at the spontaneous blood vessel growth here. Now again, think of all of our surgical guidelines. You know, the things that tell you and I what we can and can't do? What are all of our surgical guidelines based upon? Primarily blood supply issues. Well, what if we can go in and grow our own blood vessels? You know, it has the potential to change the way that we practice. This particular material is cryopreserved. This is a little bioreactor that it's grown in and is cryopreserved, and through a rapid thaw you can bring it back to life. Yeah, life. I mean, this is kind of science fiction kind of stuff. And pivotal studies show that when you bring it back, it's still producing the glycosaminoglycans, the cytokines, all of those kind of things in therapeutic range. This is what it looks like after it has been thawed. And we're in the process of cutting out a little piece here that I'm going to use on a frottage graft. It has kind of a hard plastic on either side, and then the cells and all of the other proteins and everything are on this little piece of vicryl. I've obviously already created the bed, and I'm just placing it in there. And it just lays right down in there very nicely. You go in and you suture it interproximally. And in this particular study, it was a 12-month study where we're just trying to generate keratinized tissue. And you can see here with the test site, I've stained it with Schiller's iodine stain just to differentiate the mucosa from the keratinized tissue. And our control was a free gingival graft. We also did a small pilot study where we used this for root coverage. Here you can see fairly broad, deep recession defects. I biomodified the root surfaces, went in and created a typical partial thickness flap, did our intraoperative measurements, and we cut a little piece of the material out of the bioreactor, the size that we need. You just kind of open the bioreactor, you take the cells out, and you can see I'm just placing it on the bed here. I'll suture it interproximally, currently advance the tissue up over it. And here at 1 year, we see very nice root coverage, no visible signs of inflammation. There's virtually no probing depth here. And I don't want to spend any more time on this, because you can go and you can read about both of these studies we published in 2005 in the Journal of Periodontology. I present this more as just foundation for the next generation material, which is a material that we're doing a number of projects on right now. This is one in which it was a pilot study that we were going in and trying to generate keratinized tissue. Our our control is a free gingival graft. This study is complete. It will be in your next, it'll be in the October issue of the Journal of Periodontology. I have the page proofs with me that I'll look at on the plane back, and you should have it on your desk hopefully in another month. It's already available online. And one of the neat things that Ken Corman's doing with the Journal of Periodontology is now on the online issues, some of them have videos. And this particular paper is available not only online, but there's a video that goes with it. So it's kind of cool. He's doing a lot of neat things with our journal. And so with this particular study, we're looking at a 25-patient pilot study. We want at least 2 non-adjacent teeth in contralateral quadrants with insufficient attached gingiva, and it's not a root coverage kind of study. Basically, exclusion criteria, the normal things, but we didn't allow smokers. Now, if you look at the material that we're dealing with here, it's very different than the one I showed you a minute ago. You know, the one I showed you a minute ago was just the dermis, right? where this has a well-differentiated dermis, it has an epidermis, and we've got a stratum corneum, we've got these living keratinocytes here, the living dermal fibroblasts, and then of course the fibroblasts are producing all sorts of extracellular matrix. Both the keratinocytes and the fibroblasts, like the last material, come from neonatal foreskin, so they're about as close as you can get to stem cells. They're very robust, young, vibrant cells. And the material was originally made as a skin replacement graft. And you know, if you're trying to create skin, it makes sense to make it look like skin. So here is just a piece of skin here that you're looking at histologically, and here is the test material. And you can see that it very much resembles skin. It doesn't, though, have Langerhorn cells, melanocytes, lymphocytes, endothelial cells, red blood vessel cells. It also doesn't have sweat glands, hair follicles, other things you might not want in the oral environment. But what we found and what others have found over the years in research with this, and this has been used for a long time for diabetic ulcers, been over I can't remember, I think 200,000 applications of this material. So it has a high safety profile. It's just not been used for these applications in the oral environment. And what they've found is that the important thing is not its anatomical kind of relationship of how it looks like skin. The most important thing is that when you have the keratinocytes and the fibroblasts together, they're more robust. There's lots of crosstalk between these fibroblasts and the keratinocytes, and they're synergistic. And when they're together, they're producing a lot more cytokines than they are when they're separate. You can look at the cytokine production when you have just keratinocytes and the cytokine production when you just have fibroblasts. But when they are placed together, you have all the normal cytokine production that you see in human skin. Now, to me, the interesting thing, though, is that a lot of these cytokines are the ones that you and I have been wanting to have access to for years. If you look at just some of the cytokines, BMP7, this material is producing. It's producing PDGF. It's producing VEGF. It's also producing a lot of other ones that we talk about, TGF-beta1, IL-6. A lot of these that we know are important in the regenerative cascade. So here we have a single material that's producing a whole host of different cytokines. It's producing, as the one I showed you earlier, it's some important angiogenic, the VEGF, also the basic fibroblast growth factor. It too is stimulating angiogenesis. They've taken in animals, they've infarcted the heart, placed this material on the infarct, and seen spontaneous blood vessel growth around the infarct. So again, it has the potential to really change the way that we do things. Because, again, think of one of the reasons, why can't we predictably regenerate furcations? Why can't we predictably regenerate papillas? Blood supply, at least that's a big part of it. What if we can grow own blood vessels in those areas? Has potential to really change things. Another interesting thing is that if you were to cut your skin here this morning, one of the things that happens is in a burst, your body produces a peptide called Betadefensin. And it's an antimicrobial peptide that your body produces to help that little cut heal. But it only does it in an acute burst. This material produces Betadefensin on an ongoing basis. And again, what's one of our challenges as we try to regenerate tissue in the oral environment? It's the bacterial bioburden. Why are we using chlorhexidine and all these kind of things? Well, here we have a material that's producing on an ongoing basis an antimicrobial. So again, interesting concepts that may have influence on how we use this in the future. To me, though, the most exciting thing is the fact that this is a living construct that is interacting with the native environment. Here's an MRA analysis looking at the production of certain cytokines, and here's the day you place the material into the defect. And if you follow the production of these cytokines, you'll see that some of them are upregulated as you move on. In other words, some are being more active at day 4 than they were when you put it on. And that's because it's talking to the host. It's finding out, what do you need? Okay, here it comes. You got enough, we'll shut it down. Very different than how we've acted in the past when we've attempted to stimulate regeneration. And concrete evidence that the fact that this is a living construct is the fact if you wound it, it heals. You'll see in the pilot study that we did wound this material to upregulate the production of cytokines. They found that in some of the plastic surgical studies that this was beneficial. And I naively asked early on, well, why don't you just wound it or serrate it before you send it to us? And they said, well, because it'll be healed by the time it gets to you. It's kind of wild. So here is the material at 0 hours after it's been cut. At 12 hours, you're seeing the keratinocytes beginning to migrate over the surface. 24 hours, the keratinocytes have completely migrated over the surface, and by 5 days, completely closed, a fully differentiated epidermis. We did biopsies on 7 of our patients to look at the type of tissue we were gaining, and when we had histologists that were blinded to what they were looking at, they couldn't tell any difference, just normal. This is the test material, normal-looking dermis with normal epidermis here, keratinized tissue, and this is the free gingival graft. Also, we're taking chromosomal material from one individual, placing it in another, and we want these cells to come in, they do their job and leave. So we also did persistence studies, and there was no evidence of persistence on any of the individuals that we've tested. And again, this is something that's gone through extensive testing on study after study after study. We also chose to use this material in 3 layers. And so we did a Z-fold. Now, originally you might think that, oh, well, you did this Z-fold here because it gives you the kind of the thickness of a free gingival graft. But you've got to get away from that and don't be thinking of this as a graft. We did this Z-fold here to increase the dose. We want to be able to deliver more cells. We want to be able to deliver more cytokines, all the things the cells are producing, and that's the reason we did the Z-fold. And in this particular study, we did standardize the width of the free gingival graft to 5 millimeters. The width of the test material was also 5 millimeters. And this is what we're trying to get rid of. We're trying to move away from having to put our patients through this and having to have a limited amount of donor material. This is how the material comes. It's different than the one I showed you that's frozen. This material is never frozen. It's sent to you fresh like this in this bioreactor. And here I am going to serrate this just with the idea that we want to upregulate the production of the cytokines and everything. So I'm just making a few little serrations here. The material is lying on top of a little polycarbonate material, and below that is an auger. And so I'm just separating it from the polycarbonate. And you'll see I'm going to fold it in this Z-fold, kind of like you would fold the sheet on your bed down and back, or the way you would fold a piece of paper to go in an envelope. This would be plenty of tissue to graft the entire mouth if you chose to do so. Now we're just, again, in this pilot study, we were standardizing it to a 5 millimeter width, so I'm just checking that. And now I'm going to separate it from the bioreactor. We found that it's easier to do with scissors. If you go in with the blade, the material tends to drag with the blade as you try to cut it. So I'm just coming in and separating it from the bioreactor. Now obviously we've already created the bed on the individual. You can see the little polycarbonate there. And here is our patient. We'll take this over to the bed. And then we're just going to tack it down in approximately